photograph of a patient. Below is the clinical photograph of a patient with Sezary syndrome. Question 1, what are the 3 diagnostic features of the disease? 2, list 5 clinical features of this disease. 3, how will you treat this patient? 4, what is the commonest cause of death in patients with this disease? So for question 1, the 3 diagnostic features of the disease are exfoliative erythroderma, generalized lymphadenopathy, circulating atypical lymphocytes. Then for question 2b, the 5 clinical features include palmoplantar keratoderma, which is seen in 70% of cases, alopecia, onychodystrophy, seen in 65% of cases, ectropion, facies leonina, also known as leonine facies, then hepatosplenomegaly. Then under question 3b, how will you treat this patient? So we divide it into medical therapy, targeted therapy, and surgery. So under medical therapy, there's single agent regimen and combined regimen. Under single agent regimen, we can use IV deoxycofomycin 3.75 to 5.0 milligram per meter square per day for 3 days every week, or IV brentuximab vedotin 1.8 milligram per kg 3 weekly. So this drug is actually adenosine deaminase inhibitor. Other drugs we can use is chlorambucil, prednisolone, fludarabine monophosphate. Other drugs also include pembrolizumab, alemtuzumab, mogamulizumab, bortezomib, lenalidomide, doxorubicin, gemcitabine, pralatrexate, and methotrexate. So the combined regimen includes IV methotrexate, which can be given 1 to 5 milligram per kg weekly, followed by oral citrovolume factor, this is actually 25 to 50 milligram weekly. So we give weekly maintenance for average of 23 months. Then we can also do extracorporeal photochemotherapy plus baroxetine and interferon alpha. Under the targeted therapy, we could use psoralen, ultraviolet radiation, then leukapheresis. So this is just removing the white blood cells from the blood. Then the other one is extracorporeal photochemotherapy. So this combines PUVA, leukapheresis. Then finally, you take back the blood that has gone under PUVA back into the patient's circulation. So the other one we can also do is radiation therapy. Then finally, we can also offer surgery to this patient. So one of the surgical procedures is allogenic hematopoietic stem cell transplant. So under question 4b, the commonest cause of death in patients with this disease. The commonest cause of death is actually sepsis from staphylococcal infection. So we'll just briefly look at Sezary syndrome. Under introduction, it is a leukemic variant of cutaneous T-cell lymphoma and a subset of primary cutaneous lymphomas. Most of these lymphomas are diagnosis. They affect majorly the skin. So that is why they fall under primary cutaneous lymphoma. 90% of them affect majorly the skin. It is characterized by exfoliative erythroderma, peripheral adenopathies, and circulating atypical lymphoid cells. So these are the 3 things that typically, they are the triad that we can see when making a diagnosis. First description was reported by Sezary and Bouvrin in 1938 and independently by Bakadeda in 1939. So it's commoner in older population, usually 55 to 60 years. It's commoner in males. The male to female ratio is 2:1. The annual incidence is 1 in 10 million individuals. So it's quite rare compared to the other variants of the disease. And it represents 3% of all cutaneous lymphomas. It's also commoner in whites. We'll look at the etiopathogenesis. So human T-cell lymphotrophic virus 1 and HIV infections have been suggested to have a relationship. Then also for individuals exposed to photochemicals, petrochemicals, and industrial solvents, they've also been at risk of this disease. Then this disease, central to this disease is immunosuppression. And this is usually caused by the development of a malignant clone of T lymphocytes in pre-existing benign lymphocytic infiltrates. So what happens is that the T helper cells, the type 2 T helper cells, they suppress the production of interleukin-12. So when they do this, it reduces the immunity because interleukin-12 is very important in terms of production of interferon gamma and tumor necrosis factor alpha. And this is important in protecting against tumor. The clinical features we can see in this disease, they usually start with skin conditions that mimic chronic eczema, psoriasis, atopic dermatitis, leprosy. So they can even start at de novo lesions, new lesions, or they can follow the lesions of mycosis fungoides. So they can have plaques, papules, which can be single or multiple, especially in the gluteal region or the thighs. They have erythema, which affects about 80% of the skin surface. Then also, they have palmoplantar keratoderma, which is seen in 70% of patients, and is diffuse, like in the picture that was projected for the question. The patient had palmoplantar keratoderma. So there's diffuse hyperkeratosis. They can also have scales with painful fissuring. They can have alopecia, which affects the eyebrow with diffuse hair thinning too. They can also have onychodystrophy. About 65% of them can have onychodystrophy, which is partial or total onycholysis or paronychia. Other things they can have is ectropion, pruritus, 50% of cases. Then facies leonina. They can also have hepatosplenomegaly. Visceral involvement occurs later in the disease, and the organs involved are the liver, kidney, lungs, and it can be seen in 40 to 50% at biopsy. They can also have eczematous lesions. So this is a photograph of a patient with erythroderma. You can see that it's almost up to 80% of the skin surface affected. Then this is palmoplantar keratoderma. We look at investigation. For diagnosis, we need to do a skin biopsy, excisional lymph node biopsy, peripheral blood film, and it will show us Sezary cells, which are also known as mycosis cells, Losner cells, or cerebriform lymphocytes. These cells typically have a grooved nucleus, which is also infolded. For the diagnostic criteria, there's a cytomorphologic criteria and also a blood criteria. Under the cytomorphologic criteria, we look at the small cell variant, large cell variant, mixed variant. And this is just a picture, peripheral blood film, showing the Sezary cell. The grooved nucleus can be seen. Then under the blood criteria, there's an absolute Sezary cell count of 1,000 cells per millimeter cube. Then increased CD4 to CD8 ratio, greater than 10 or more. Aberrant expression of pan-T cell markers by flow cytometry. Increased relative or absolute lymphocyte counts can also be seen. Then when we do the biopsy, we take it for histopathology. The findings are usually specific because they can be seen in some other conditions. Acanthosis, parakeratosis can be seen in psoriasis. And other things we can see are dermal lymphocytic infiltrates, portals microabscesses, prominent papillary dermal telangiectasia, perivascular lymphocytic infiltrates with a moderate and focal epidermotropism. So epidermotropism means that the white cells are moving towards the epidermis. It can also be seen in other conditions. Then we can also do immunophenotyping. So we are looking out for CD4 plus cells, CD3, CD7, CD26 cells. Then polymerase chain reaction also detects T cell clonality. It's also very sensitive. Then we can do other investigations like bone marrow biopsy, which will show moderate infiltration, less than 20% by atypical lymphoid cells. Okay, and full blood count will show increased or normal WBC. The other things we can do is serum iron, LDH, which is increased and is a marker of poor prognosis. Then serum electrophoresis. For the staging, we use TNM staging. So I won't bore us with this. But we would like to know that patients usually have stages 4A1, 4A2, and 4B. For medical treatment, I've already mentioned the drugs and the regimen. So the differential, one of them is mycosis fungoides, the other one psoriasis, pityriasis rubra pilaris, dermatitis, scabies, graves or So's disease. So we look at the prognosis. So poor prognosis associated with late stage of disease, elevated LDH, male sex, peripheral eosinophilia, follicotrophic mycosis fungoides. In conclusion, Sezary syndrome is a distinctive ectodermic cutaneous T cell lymphoma with leukemic involvement by malignant clonal T cells. The diagnosis is stronger if the same clone is demonstrated in the skin, lymph nodes, and peripheral blood. The main aim of treatment is controlling symptoms and improvement of the quality of life. Thank you for listening.
Thank you so much, Dr. Amadi, for the beautiful presentation. So now we'll take comments, questions from the participants first. Okay, let me ask my own questions. Thank you so much for that wonderful presentation. I was just wondering, is there anything like non-pharmacological treatment for this condition? And then I was wondering how the erythroderma will appear in blacks, because that picture I showed is that of the white person. Then I also want to, in the triad, you say the third one was atypical lymphocytes. So I was wondering, the atypical lymphocytes, that seems as the Sezary cells. Okay, thank you.
So for the non-pharmacological treatments, I think it's mostly supportive. Like if the patient has erythroderma already, you want to make sure you do a reverse barrier nursing for the patient. Try to make sure the patient is well hydrated. Then also, because this patient, they can have some problems with temperature regulation, so you also try to make sure they're in an environment that is not too hot or not too cold. Those are the ones I came across. I don't know, is open to contributions. Then for the picture, the one I actually put up is that of I think it's a black skin. Let me just go to the picture. I think it's a black skin.
Okay.
But I'll still look for other pictures. I saw a couple of pictures. I even saw the ones in a white skin, then also in a black skin. Then the atypical lymphocytes, they're also called the Sezary cells because of the difference between what you see in the normal lymphocytes. For them, they have that groove nucleus. They also have a pale cytoplasm, and they resemble the brain. So that's why they say the cerebriform appearance of the lymphocytes.
All right, thank you so much. I don't know, do we have more comments and questions? Okay, so Dr. Aminu is saying, thank you for the wonderful presentation. As part of the supportive care, is there a role for use of emollients?
Okay, so I would think there would be a role for the use of emollients, because depending on the lesion that is seen, because remember I said they can have lesions mimicking contact dermatitis. So if they have those lesions, there will be a role for emollients. So they can have even plaques depending on the stage, because even in the staging of the disease, they can have different stages of the disease. When it's obviously erythroderma, they will now need other forms of treatment or supportive treatment. So yes, they will benefit from emollients.
Okay, thank you. Okay, so that one of their symptoms could be itching. I don't know. Did you say anything for the
Yes.
itching?
Sorry, I forgot to put, yes, they can benefit from antihistamines. Actually, it
Okay.
was an omission. I should have put it. Yes.
Okay, any place for antibiotics in them?
Yes, especially when they start developing complications, because sepsis is one of the most feared complications. So they'll benefit from antibiotic use. Okay.
Okay, thank you. Okay, Chief Linda, please go ahead.
Okay, thank you. Good morning, teachers. Good morning, presenter. Thank you for your presentation. So I just wanted to weigh in on like the presentation in dark-skinned people. So in dark-skinned people, like you said, depending on the form of lesions they come with, but generally you can find out that they may have generalized scaling, and then they may be they may have this hyperpigmented hue. They may have this darkish hue. The person may look a bit darker than they were. And then, okay, we talked about the pruritus as well, and it may also come with intense xerosis. So the role of emollients cannot be overemphasized. Other forms of non-pharmacological treatment also is psychotherapy, because it's very, very disfiguring. And so the person needs some form of psychotherapy, family, emotional support as well. Then, of course, the reverse barrier nursing and thermoregulation is very, very important here. And also nutrition, because a number of them may have some exfoliative dermatitis. Basically, the skin is failing. They will have hypoproteinemia as well. So dietary therapy is very, very important. And then also for the what was it I wanted to talk about? The Sezary cells are just a lot more bigger than the normal or the other lymphocytes. And then the edges, looking like you said, there's a reduced nucleocytoplasmic ratio. They're a lot more basophilic, and then the edges of the cell, they are kind of like corrugated, like how you'd see gyra of the brain, gyra and sulci. So that's why it's called the cerebriform type of lesion. And also, okay, yeah, I think those are the points I wanted to give. Thank you.
Thank you, Chief.
Oh, thank you so much for that beautiful for that
Sorry, and
beautiful add-on.
antihistamine, you can also give antihistamines to, also some people can use steroids to can also play a role in the management of the patients. Largely, like you said, that superimposed infection most of the time is the cause of death for these people. So antibiotics also play a role for wound therapy if they have tumors that are ulcerated. Most times the tumors are ulcerated. So of course you can do wound dressing and then antibiotic therapy if needed.
All right, thank you so much. Chief Linda, I just want to ask you, how common is it? Do you actually have cases?
So well, for mycosis fungoides is let me say, in our environment, I think the issue is diagnostic ability. I think I've only seen two, but I've actually seen one in a very, very young person that history started from when she was when she was before she became a teenager. That was when she began to have history of people were thinking it was atopic dermatitis, psoriasis, different forms of eczemas, until she became an adult, and then we found out that it was actually a malignancy. So diagnosis can be a bit difficult. especially if it follows the mycosis fungoides path, not just coming as Sezary syndrome right from the onset. So we don't really see a lot, but I think they are out there. Thank you.
Well, thank you so much for that add-on. Thank you so much. Okay. Dr. Maduka is saying thanks for the presentation. Thank you so much, Dr. Ilumba, for the beautiful presentation. Okay, so in absence of any other comments, I'll hand over to our teachers. My Christabel. Okay, ma, I can hear you.
Hello, Dr. Kele.
Okay, I can hear you now.
No, it just was a call. The call came. I don't know why people are funny. Someone is interrupting your call. It shows the person is busy. They just keep calling. Gotta see if I beg. I must appreciate Dr. Ilombo. I didn't expect anything less. So she's wonderful doctor. Thank you so much. That was wonderful. Dr. Linda, as always, thank you. Dr. Awa, I didn't hear your voice. Dermatologist, Dr. Ifoma, Dr. Becky, I didn't hear your voice. Thank you, Dr. Linda, for repping the Dermatology Society. As always, we appreciate you. So I just want to come in quickly, just so the caller will not interrupt me again. It was a wonderful presentation, but the way you presented it showed you've not really managed anything. Like what we always say, no matter the dermatologic condition, really, emollients are always very important, because one common characteristics with all of them, except those that are infected, except those, even those we still encourage emollients. Emollients and dermatology, they are 5 and 6. Emollients and skin conditions are 5 and 6. Think about it. No matter the condition, if those people that have done dermatology posting, you see we are always prescribing emollients. The common petrolatum jelly, which we all know as Vaseline, any of the emollients, they are very important. It helps. A moisturized skin is a happy skin. So emollient will always come in. So remember, for this condition, there's pharmacological and non-pharmacological. And it's the way you speak the pharmacological, they'll know that, oh, this person has if you've not even seen, they've not be part of the management, just the way you speak about, and this actually is a general principle really. Emollient comes in, and those conditions that have exfoliated dermatitis, mean the skin is peeling, they are losing skin, any of them that causes any form of exfoliation, you know that you will have to weigh the scales, gather the scales, and weigh the daily high protein diet. Then emollients comes in, and you monitor that input output, because once they are losing fluid, or once they are losing some important proteins, they are at risk of having acute kidney diseases. And also for someone that is also prone to having infection too. So that shows that such persons should be monitored closely. So for the non-pharmacological, weigh your patient daily, weigh the scales. It will help you to know if the scales will help you to know at least the protein you should give to the patient, the quantity, or at least if you are losing 6 grams of skin every day, you know that you should not go less than that for your protein supplementation. I usually encourage animal source of protein, high protein diet, majorly from animal source. Then monitor input output, encourage fluid intake. Then comorbidities. People that have this condition, they might have other condition, because somebody have Sezary syndrome doesn't mean the person cannot be diabetic, doesn't mean the person cannot be hypertensive. Remember how you said that this condition is mostly in middle age and elderly. So as people age, some people have up to like 2-3 comorbidities. I'm in a meeting. Some people have 2 or 3 comorbidities. So all this, so always make sure, if there are any comorbidities, I might want to manage it at this point. Then we also encourage that if you're given a topic, it's best you see the specialist in that your field. It really help you bring it home to you. You never can tell, it might just be a patient that is being managed for that particular condition at that particular time. So it will make it easy for you to quickly go through it and personalize it. You will not need to cram because you are seeing the patient directly in front of you. It will just make a lot of things easier for you to understand. So anywhere you see this particular question again, anywhere, any of the exams, we're all writing different exams these days, both African exam, American exam, European exam. So any of the exams you see, any of these, the dermatology questions are quite common. Any of these exams, you are woman, you are okay with any of these questions they'll throw at you. So I think we're managing a patient currently, and this patient is on weekly gemcitabine, and this patient, I think it fits into water. Dr. Linda, are you in Guagalada?
Yes, Chief. We sent her to you guys. They change it to weekly.
So she fits into a lot of things that my dear brother was talking about, a lot of the things. So if you have seen her, because she comes every week, I'm in a meeting. She comes every week. So, and such patients, I think about how many weeks ago, where she came down with severe sepsis. We're almost scared that she was having neutrophilic sepsis. But luckily for her, it was just sepsis. So she had been on antibiotics. So you go to your own facility, know if some of these cases are in your facility. So you go through such patients to personalize and make you understand the presentation better. So, but overall, I don't know if I missed anything. Overall, it was a wonderful presentation. So thank you so much. And this condition, just wait, doctor, because we also have another person that we diagnosed recently. They were thinking the patient has oncodermatitis because it's mostly peripheral lymph node enlargement. But we did biopsy and it was mycosis fungoides. So it mimics, it's a great mimicker of a lot of things. It's a great mimicker. So most time people will managing them for other conditions. Then do not realize later on. That's why we always insist, please, before you start treatment, do a biopsy. That way, and sometimes for those that have mycosis fungoides or any of these skin condition, because any skin condition really can progress to mycosis fungoides and further down to Sezary. If let it be atopic dermatitis, psoriasis, any chronic condition really can progress to mycosis fungoides. So that's why anybody that have been managed for a skin condition over a long period of time usually advise a frequent, not so frequent, but timed biopsy. Don't just do a biopsy and that is it. Like 6 years, 10 years down the line, you repeat. You want to be sure that it has not progressed to mycosis fungoides. So I hope I was able to say all I had in mind to say. But once again, Dr. Lambo, thank you so much. That was wonderful. Dr. Linda, thank you for your wonderful contributions. Thank you. But one thing I also say that just more about that. Can you hear me?
Yes, ma'am.
They respond poorly.
I wanted to ask if the way he said the triad, is it okay that way? Extradermal lymphadenopathy and atypical lymphocytes, or you're saying Sezary cells?
We can say Sezary cells, but most time it's best, it's best to just say things to be more specific. So I think Sezary cells is actually better. But if you don't say atypical, it's also fine. It's actually the same thing. But somebody that might be sometimes in these exams we go for, sometimes human beings, they may be distracted. So when you say Sezary cells, it makes better sense to them than when you say typical lymphocyte. So any of them is fine. Anyone you remember is fine. Actually, you get your marks.
Okay,
so
thank you, ma'am.
Respond poorly to them, and they respond poorly to chemotherapy. Actually, this condition is very difficult, very, very depressing. It's very depressing to manage. They respond poorly to chemotherapy. So one thing that's where clinical psychologists come in, because you do a lot of psychotherapy for these patients. Really, you might start one chemotherapy, they might not respond. They respond really poorly to chemotherapy. I just want to quickly break that one up, just in case this thing is altered in any of the exams we are preparing for. Thank you once again, Dr. Elambo. I appreciate you. Dr. Linda, thank you for your wonderful contribution. I don't know if any of our teachers have any contributions. Our dear Chief Cookie is in class. I don't know if I said Chief Bansi, Chief Chitu, Chief Emigus, Fatima, Okopi, Success, Dahatu, all our wonderful teachers.
Well, you have said it all.
Okay. All our wonderful teachers. Okay. So thank you so much. Thank you. Thank you, Dr. Elambo. I appreciate you. Thank you once again.
Thank you, Chief. I'll make the corrections, Chief. Thank you.
Please, and one more thing, please. That Sezary cells, we can just put a picture or the big pictures on it, just in case.
Okay.
So that
Okay.
they might not bring a human being, they might not bring just the Sezary cells for you, just in case. Just add it to your slide, please.
Okay, Chief. I'll do that.
Thank
I'll make the corrections. Okay, Chief. Thank
you.
you.
I appreciate it. Thank you.
Okay, ma'am. Okay.
All right, thank you so much, Dr. Ilombo. Thank you, ma'am, your teachers. Thank you, Dr. Linda. Okay, Dr. Momodu, please go ahead. Dr. Ilombo, we cannot share. Okay. Thank you so much, Dr. Momodu, for standing in or accepting to stand in for us. Okay, please go ahead. Hello. Please, can you stop the recording? Yes.
And the question goes as thus: a 45-year-old female with multiple small and large joint pain and swelling and joint stiffness that lasts the whole day and swelling on the extensor surface of the left elbow. List 5 differentials and defend each. What is your diagnosis? List 2 serological tests you will order, and then classify DMATs with examples. So first differential will be rheumatoid arthritis. They made mention of symmetrical involvement, and there also persistent joint stiffness that lasted the whole day, which also puts it as a very strong differential. And lastly, the presence of a lesion on the extensor surface of the elbows, which is one of the commonest parts where the rheumatoid nodule could also come out or present. So on account of these three, rheumatoid arthritis, the differential, I just put this to actually show the rheumatoid nodules which could occur in the elbow of a patient. Then psoriatic arthritis too, it can affect both small and large joints, often causing stiffness. Of note is that this could also last greater than 30 minutes. However, it is mostly alleviated on physical exercise. It could present from either a distal arthritis pattern, asymmetric oligoarthritis that's affecting more than one, but less than 5 joints. It could also be symmetrically polyarthritis, where it affects more than 5 joints symmetrically. And also it could come in as spondyloarthritis, as we saw here in the question, said based on the large joint. So it could also have the sacroiliitis with it coming in. This could also potentially be a differential. And also the hallmarks for psoriatic arthritis, they might have enthesitis, where this joint attach, most especially even on the extensor surface. They could also have tenosynovitis and dactylitis, which could actually potentiate more of a psoriatic arthritis. Then another, because of the extensor surface lesion, Gout could also be a differential, whereby we will know this the position of uric acid or the TOFA is there. However, for gout, they will typically present episodic rather than having chronic stiffness. Then systemic lupus erythematosus could also be part of it. It could affect polyarticular joint or polyarthritis of both small and large joints, and also with stiffness. However, it has the pain occurring more moderately, and then when we do the x-rays, might see no erosion. So you could also have subcutaneous nodules from the lupus on the extensor surface of the elbow. So osteoarthritis typically will be more, it tends to be more to affecting one joint rather than being symmetrical on both. And although it can occur symmetrically, then the morning stiffness and pain typically lasts less than 30 minutes. Then also, there could be some associated bursitis or synovial hypertrophy that could occur as in terms of in keeping with the lesion on the extensor surface of the elbow. Then what's a most likely diagnosis? With this presentation of persistent stiffness lasting all day, symmetrical joint involvement, and possibly swelling on the elbow, which is the presence of rheumatoid nodule, my likely diagnosis will be rheumatoid arthritis. So list two serological tests we want to do. I want to do the rheumatoid factor, is to check the presence of antibodies associated with rheumatoid arthritis, which is said to be positive in about 70 to 80% of cases. And also the anticyclic citrullinated peptide, and is a bit more specific for rheumatoid arthritis as compared to the rheumatoid factor, and can predict an aggressive disease. So how do we classify DMARDs? The DMARDs typically will be classified into those that are biologics and those that are synthetic. So in the biologics, we can have examples, a subclass of tumor necrosis factor inhibitors like etanercept, infliximab. Then for the interleukin inhibitors, we can have tocilizumab, which is an interleukin-6 inhibitor, and Ankira interleukin-1 inhibitor. Then we could also have biosimilars, because recently we've been finding it that these drugs can be quite expensive. So there's room for, after patency, more like a copy of the same biologics that are now used. So more or less biosimilars, they have reduced price, but they have similar efficacy with the original biologics. So biosimilars are also there. Then the synthetics, which could be conventional or targeted. So it's of note that one of the most very important synthetic DMARDs, methotrexate, is actually the first line treatment of rheumatoid arthritis. Sulfasalazine is also one, commonly used for inflammatory arthritis. Also hydroxychloroquine. Then the targeted are mostly the Janus kinase inhibitors, tofacitinib and baricitinib. This is just to show the same thing, but however, just wanted to put the biosimilar DMARDs, which is also biologic. You can have the biosimilars for etanercept, rituximab, adalimumab, infliximab. Then I just wanted to briefly talk on the pathophysiology here as regards some of the clinical presentations of rheumatoid arthritis. As we know, it's a multi-systemic disease, and if not inflammatory disease, and if not treated at the early stage, it can become so debilitating as to become systemic and cause lots of problems. So it's actually a genetic and environmental interplay, although we'll say that it's mostly with the HLA-DRB1 or STAT4, and a possible trigger from the environment, be it infection, smoking, sex hormones, and this will elaborate the activation of macrophages and dendritic cells, who are thought to be sensitized when they are presented, when they bind to these antigens, and activation of T cells, T cell proliferation. So it said that the activated T cells produce inflammatory cytokines, interleukin-6, tumor necrosis factor alpha, and interleukin-2, which stimulate B cell differentiation into plasma cells. So it's these plasma cells that often produces the characteristic antibodies that we want to check for. So the anticyclic citrullinated peptide and also the rheumatoid factor that we see in serum. So there could also be non-specific acute phase reactants, which can also be produced, which we also see in serum. You can see the CRP and ESR. So with all of this activation of these T cells, B cell proliferation, there is destruction or reduced production of hyaluronan, which is a major lubricant in synovial fluid, and also increased metalloop proteinase production with further increase or destruction of the cartilage. And these plasma cell antibodies form immune complexes that indirectly also damage cartilage. So as we can see, because this is quite systemic in a way of which is not localized to one place, you typically will see the symmetric pattern rather than just having a unilateral or one-sided pathology. So with all of this happening, the stimulation of the nerve endings in the subchondral bone and synovial membrane. So typically we see the symmetrical polyarticular arthralgia, and most especially in the small joints. Then also with the rate of inflammation occurring in the synovial joints, it could actually exceed the capability of the drainage for the joints. So they can have joint effusion, of which we will see in the x-ray. So with further damage to the joints, the cartilage then further in terms of adaptation becomes more hyperplastic, more cells. So that develops what we call the panus. We just make a makeshift, or as a result of insult from the synovium, where there are now more cells added to it, but it's poorly adapted. And over time, that can erode into the bones and ligaments, and also cause some of the subchondral bone erosion. Of note is that as against osteoarthritis, that this rheumatoid arthritis still has some of all the subchondral sclerosis, but erosion is very common here. So you typically will see erosion in osteoarthritis. And when all these deformities come in, we can now see some of the typical features that we can see: the swan neck, bottleneck, the ulnar deviation of the fingers or some of the joints. So if left untreated, the rheumatoid arthritis can affect the entire body and now have a systemic inflammation, which could also cause all those extra-articular signs. So thank you for listening. That's the end of the presentation. Thank you so much.
So wonderful, a beautiful presentation. Okay, so now we'll take comments and then questions from the participants first. And let's keep the things coming on the chat. And then thereafter, I'll reach out to come in. Okay. Dr. Adewinto is saying thanks, Dr. Mawada, for the excellent presentation. Okay. I was just wondering, can SLE be a differential here?
Okay. Just as I've said, the SLE2 can affect joints. It could, typically they can have arthritis and arthralgia, and it occurs in over almost 90% of patients with SLE. And it's often one of the earliest manifestations. However, it could be migratory, it could be polyarticular, and mostly symmetrical. So the arthritis typically that will occur with SLE doesn't have much pain, and it does not cause erosion like rheumatoid arthritis. However, they could also have SLE nodules within. So I actually put that because of these features of arthritis and also the swelling on the extensor surface, which could also be a lupus subcutaneous nodule from SLE.
Okay, sorry, maybe I missed that. Okay, Dr. Temi, please go ahead. Thank you.
All right. Good morning, teachers and colleagues. Thank you very much, Dr. Momodu, for the beautiful discussion. I just wanted to add to the differentials because I think they said we should list 5, and maybe I missed out. I think you listed 4. So, other the additional differentials, you mentioned psoriatic arthritis. So it will be good to like mention some other members of that family, the spondyloarthritis, the other ones that are peripheral. So also it could also be reactive arthritis could be a differential, but in this case, they didn't give a history of a preceding illness, febrile illness, but it's a possibility can cause arthritis involving the extremities too. Then another member of that family, IBD associated arthritis as well, but also there's no history of a chronic GI illness, but that's a possibility. Then also sarcoidosis can also cause arthritis and can also cause a skin lesion where they described. So that could also be a differential. Just to add to the differentials here. Thank you.
Thank you so much,
Thank you
Dr.
so
Temi.
much. Thank
Okay,
you.
Dr. Smith, please go ahead.
Thank you very much, Dr. Mamoudou, for that presentation. When you are listening to your differential diagnosis, I don't know from the history, is there anything that is leading? Because from what I saw, it looks like you manage rheumatoid arthritis. So I wanted to ask, in the history, was it, what are the main things, main points or parameters that you use to manage the rheumatoid? Then in case in exam, this is my teachers and other, in exam setting, if you're giving this kind of question, are we to, because from the question there was nothing asking for history to establish diagnosis or rest. So how are we to approach it and probably manage one? Because that was ultimately what they were asking. Why not also arthritis? Why not gouty arthritis in this case, or other form of seronegative spondyloarthritis? Thank you.
Okay, thank you so much. To answer your question, these features given actually fit into rheumatoid arthritis. I tried as much as possible to link them up the best way I could. However, we'll need more history to actually get the diagnosis. Why I picked rheumatoid arthritis is this is symmetrical involvement. And also, there's a very significant point they gave, swelling and joint stiffness that lasts the whole day. So typically, you see that more in rheumatoid arthritis, psoriatic arthritis. Most other ones would not extend the whole day. So that's also a particular feature. Then the commonest presentation for most especially the rheumatic nodule, where it is cited, typically is the extensor surface of the elbow. So the others could appear, although they could appear everywhere, but it's almost when you're looking at rheumatoid arthritis, typically the extensor surface of the elbow, you see the rheumatoid nodule as against the others. So that's why I put that as first, although I will still preferably want to do more. Then if you look at the follow-up question, it said 2 serological tests. So typically, if you look at the other ones, the serological tests might not be, although you might have, but they might not be too specific to it. So we know that the plasma cells secrete those those antibodies, the ACCP and the rheumatoid factor. It actually directs your thoughts towards going to rheumatoid arthritis. Then also, I know the DMARDs can be used for other, they can be used in other conditions. But here, I was being told to classify DMARDs. So I would use that as more of, how do I put it now? A guide towards knowing what I'm answering. Although it can be used for the other spondyloarthritis, but the DMARD actually.
Sorry, hello, Dr. Jafaro, sorry.
Yes, sir.
It depends on the exam actually. Sometimes you might not be privy to all the other questions. Okay. So maybe it will just be these 5 differentials and defend each. That might just be the only question that you are privy to at that particular point in time. So it's subsequently that the other ones will come up. So your defense has been good. Don't add those other questions to it. Just use the history, okay? Look at all the other things. The joints involved, multiple small and large joints, the age of the patient, all those things. Those are the things you're supposed to use to defend your diagnosis, okay?
Okay, sir. Thank you so much, sir.
All right, thank you.
All right, thank you so much, sir. Thanks, Dr. Tim. Thanks, Dr. Sunny. Thank you, Dr. Momodu. Okay, so now in absence of any other comments, I'll hand over to our teachers. Mr. Bell.
Sorry. Hello, thank you, Dr. Ekele. Thank you so much. Dr. Momodu, as always, we appreciate you. Hope I can be heard.
I can hear you, ma.
Hope I can be heard. Thank you so much, Dr. Momodu. I appreciate you, really. You are such a wonderful person. Thank you, thank you, thank you, thank you. So, he has done well, as always. I don't have any comments. Thank you so much. I don't know if any of our teachers have anything to add. Chief Cookie, Chief Bansi, Chitu, Remigus, Fatima, Okopi, Success, Dahatu. Any comments from our teachers? So, Dr. Mamudu, you are bamboozled of course. You did wonderfully well. Thank you. Thank you so much.
Thank you, ma'am.
Are you speaking like you're already a fellow, by the way? So congratulations. Thank you so much. It's still Chief Bansi, sir. Can you help us close the class?